Hi, Russ. This is Barbara Wash from the Department of Medicaid Services. It is 1 p.m. and I'm still clear in the waiting room.
Okay, we'll give it a minute or two.
Okay. So currently, Russ, we have yourself and we have Elaine, and that's what we have so far. If anybody else is on, maybe they're calling from a phone I don't recognize. We're missing Lori Ritchie Baldwin, Michelle Lawless, and Chris McClurg.
Yep. Okay. We didn't have a quorum last meeting, did we?
We did not.
We gotta make sure we got that going forward. Okay,
Okay.
so I will, I'll make sure we've got it going forward.
Okay. Um, So, Russ, just to get started, I want to introduce to you all, we have Danielle Davis, who will be the BACMAC and TAC coordinator. And Danny might want to say a few words.
Great. Welcome, Danny.
Mhm.
Hi, it's nice to meet you all. I definitely look forward to working with you, and please feel free to reach out to me as a resource moving forward.
Great, thank you.
Okay.
All right, we're gonna go ahead and get started. We do not have a quorum. Then we cannot approve the minutes from the last two meetings. So get into new business. The first item is the A trip. So we've gotten notice of our 2026 approval and the rates. I appreciate the DMS and all the effort they put behind it. It was good news that we got updated rates for the 2026 calendar year. Um, the question I think that we have, some hospitals have, is that so in the past we've set a target for the A trip amount. So in 2025 it was I think 2.4 billion, but I think we ran uh, higher than that all year to the point where it was going to be. I think the projection was 2.7 billion maybe at the end of 2025. My understanding is that in prior years, DMS has gone and asked for approval for the overage from CMS, and that's been given. What I also understand is that in this current year, 2026, that can't happen again. That won't happen again. And I just need to confirm that. That's one of the questions. I think if that's accurate, then the question is that if we have a budget of 2.8 billion for 2026, what what is the process to keep us from going over it, or how are the payments going to work, or what is the, are we going to pay payments to, out until we reach the cap and then be done? Are we going to split it up by quarter? There's a lot of unknowns about how this would work in the 2026 year. I don't know if Steve's on, but I know that's a question that I've heard from multiple hospitals over the past couple weeks since we've gotten the approval.
So I did not Steve on here?
Yeah,
I'm looking. Oh, he is.
th-
Okay.
this is Jacob Wilson. Steve's
Uh,
having trouble getting on to the Zoom call. So we
okay.
might have to push this topic maybe down
Okay, we can do that.
until he gets on. Yep.
Yep, we can do
Okay.
that. Thanks, Jacob. Okay, so we'll put that on hold to see if Steve can get on. Under old business, we've got delivery and newborn issues, the prior authorizations. So we uh, we had issues with progeny health level of care audits. I know Becky Harris may be on to talk about this as what this issue is that we had an MCO that was using Progeny Health. If the level of care didn't for the newborn didn't match the authorization exactly, they were getting paid zero for newborn claims. And I know we brought this up with DMS that that all newborns should be, our viewpoint is they should be retro eligible and it shouldn't require prior auth, and there shouldn't be a denial for authorization where there's a zero payment. And I know, so Becky, are you on? I saw you on there.
Yes, I am.
Do you want to give us an update on at least where you're at with them?
Sure. I kind of break these down into three issues to your point about the retro and no auth denials, where technically an authorization should not be required. Secondly, we have Progeny who is issuing authorizations by day for level of care, keeping in mind some of the babies of UK healthcare are here for hundreds of days. And when the billing for those levels of care do not match exactly to the authorized levels, paying zero. And then third would be Progeny and the DRG downgrades. This is, we do consider this global. This is not UK healthcare alone, but our current status, we have had some progress in getting some of our claims paid. However, just to provide some context, we have a team at UK. We're currently working 56 accounts worth about $2 million net to us. And some of these accounts include babies who have been here nearly 200 days. So that is exclusive of those that we have resolved. So lots of issues around the babies, lots of issues.
You on mute there, Becky. You went to mute. Sorry.
Oh, I'm so sorry.
It's okay.
What was the last part you heard? Did you hear the stats I was able to provide?
You said lots of issues with the babies after like a couple hundred days.
Um, yes, so we to put some stats around the issue overall, we have a team at UK. We're currently working 56 accounts, which
Okay.
is worth about $2 million net. Some of those babies have been here in the neighborhood of 200 days. So it's a lot of our level 3 and 4 babies tied up in these figures as well. We have made some progress in getting some babies paid, but those figures are exclusive of anything resolved today. So some progress, definitely not resolved at all.
Hi, Russ and Becky. This is Pam Trigilio. I'm the Associate Director for Humana Healthy Horizons, and I would like to provide you all with just some actions that we have taken regarding this issue, if that's okay.
Okay.
So as of 1/16 of this year, we did reprocess 184 claims. Of those, 118 were repriced based on that authorized level of care. The remaining claims were denied just based on other edits within our system. So for instance, could have been COB, could have been duplicate, so forth. As of 2/16, we did complete a second claims impact analysis to address the more recent claim submissions with that same denial. We did submit another IPAR request for 107 claims. And then our system was also updated on 2/23 so that that does not continue to happen. So we will actually be submitting a third IPAR for claims that were missed within that second IPAR. Going forward, we are reviewing some of our provider educational materials for potential revision. That's so that we can better inform our provider partners regarding the process. So Once we get those revisions figured out, we will submit those for approval and we will provide re-education to our providers. So I hope that helps some, Becky. I believe that we shared with you all too the claims that have already been reprocessed. Our PR reps did. So I don't know if you've had a chance to look at those yet.
You have, and the figures that I provide are amongst two different MCOs and those that have not processed to date.
Okay.
So Becky, who's the other MCO?
Passport Millennium.
So Pam, is the prior auth denial for zero stopped? Is that what I hear you say?
As of 2/23.
Okay. Anybody from Passport or from DMS? I know. So the message we got at our last meeting from Dr. Terrio and Justin was that they had an internal discussion and they were a group that they were working on it, and we were awaiting the response too.
Yes, sir. So this is Justin Derringer with Department for Medicaid Services. We are working, reviewing these issues with Humana and Passport, and so I think they are working on those issues as well. So hopefully we'll have those issues resolved. I know they're both managed care organizations are working on the issues that they had, and we're working on creating some information for those managed care organizations to make sure that they comply with those things. So, because it's just a couple of MCOs of specific issues, there probably won't be a provider letter, but we are working with those two MCOs to make sure that the issues of zero payment, and then there was another issue of um, making sure that we had, and I think that's a little bit farther down, but making sure that any type of denial or downgrade, that there is clear, specific reasoning why, and that you all are given opportunities for appeals through those any type of denial or downgrade. So those are the two specific issues that we're going to be working with our managed organization partners on for this specific issue. And then there's another whole different kind of work group that's going on that has to do with neonatal newborns, and that's a little more complicated, and we're still working on that. Dr. Terrio's heavily involved with that. She's been out for a little bit, so as she gets back, we'll resume those meetings, and we'll have something further on that specific part of this later on.
Okay. Anybody from Passport with an update similar to Humana?
So Russ, I have not seen anybody on from Passport. Oh, there might be someone. Is that Lori?
I've
I
got
don't
more than
see
one
anybody
column.
there. Yeah.
So I've got a quorum now. It's great.
Yay.
Sorry for my delay.
That's all right. It's all good. All right. Any questions on this item with a delivery newborn prior auth issue?
Yeah, Pam, you mentioned a report you shared with U of K. If we still need a report, can we reach out to that for our claims here at U of L?
Absolutely. Yes, please do,
Thank
Crystal.
you.
Thank you. Mhm.
All right. So we'll go back to the top, establish a quorum. I know we've got the minutes from the old meeting that were sent out, the prior meetings. Can I have a motion to approve those?
I'll make a motion to approve them. Russ, it's Elaine.
All right.
Lori, I'll second.
Okay. And favor is aye. So those are approved. All right. We'll continue on the old business before we go back to the new business item. The COB issues. I know there was I got some correspondence or an email from cabinet. We sent a response. It's we've got reports of take backs because there's There's another coverage, but the MCOs are not giving us the information on the third party payer. Gamewell the info gets sent out to the MCOs. We can't get it from DMS. We don't. There's a lot of examples where we don't even know who the primary payer is, and there's no way to reconcile the COB issue. I know we had a discussion. I know that email was sent with, and then we had a discussion last week. Is there any update from? And I know we were looking at examples. Rosman, do you know if we got those examples to the cabinet?
Hi, Russ. I don't have that confirmation because we wouldn't be able to see those examples for HIPAA
I get it.
reasons. But we do have several hospitals on the line that may have sent examples.
And Russ,
So
we
this
do have
is,
Chris Turner on from DMS. Sorry, Chris.
Hi, Chris.
that's okay, Barbara. Hi.
Mhm.
Hi, Russ. Yes, so Teresa couldn't be here today. She's actually our TPL SME, but I did speak with her prior to this, and to date, we haven't seen any examples yet from the hospital. She and I did meet, and we did kind of draft up a little template that I'm going to drop into the chat of exactly what it is that we need from the hospitals as far as detailed examples, where you can send that. And we're actually asking if you all can get those examples back to us in about 2 weeks. We're asking for it by maybe March the 13th. That way we can get a good sampling submitted to us. We can kind of look through those, review, and start addressing some of those issues that you all have brought up.
Okay.
Appreciate that, Chris. Thank you. And this has been a long-standing issue for hospitals. It's been kind of on our radar that we've shared with DMS for over a year. And I do know that we have at least one hospital that might have the ability to kind of provide an overview just for this meeting, and that might help provide a little context when those examples come in.
Okay. Certainly. And I did drop that information in the chat. And I also spoke with Jeremy and Chelsea, and I believe they're going to try to get out a detailed email possibly to you, Rosalind, in case you want to send this out to the KHA, so that all different providers have that if they want to submit additional information as well.
Sure, I'd be happy to. Thank you.
So Rosman, who do we have on that could provide information for the record?
This is Chris Wilson from Norton Healthcare.
Hi, Chris.
Hi. Yes, I was asked to provide some examples. I did try to submit at least one of those examples today, and it was sent back by DMS because we attempted to encrypt it so that the PHI wasn't captured. So I will be following up. I will resubmit that without the encryption included so the DMS gets those examples. However, I wanted to just kind of provide some insight into the issue that we've been discussing on the KHA. And this really started for us back about the 2022 and 2023 years. Passport by Molina had brought in a third-party entity conduit to assist them in identifying primary coverages to the Medicaid line of business. And what happened in hindsight is that a lot of times that vendor identified previous coverages that had termed, but Passport went ahead and loaded those files as if it was open-ended coverage that had not expired. And then they began to recover previous primary payments from us, even though after researching it, we found out Passport was still the primary coverage because the commercial coverage or any other coverages had already been termed. So those were just automatically loaded. The recoveries took place. The issue that we encountered with those is the way that they were recovered was a full recoupment of the previous claim. What then subsequently happened is when they recovered at the claim level, they then gave us a TPL offset in the check section of the remittance to basically balance out the offset that they had taken, but it doesn't contain any claim information. So from our standpoint as the provider, Passport recovered the entirety of that claim. And because the check level information is basically normally reserved for stuff like interest that doesn't go back to patient claims, then we had an undistributed balance that we had no ability to tie back to a particular claim. So they gave us the money back, but we don't know of the 100 or so claims that were adjudicated in that remit, which ones were taken back and offset by this TPL adjustment. The other concern that we had in this is where Anthem was involved as the supposed primary coverage. A lot of times Passport just went to Anthem and recovered the money that was paid as primary, so that when we found out what had happened, when we attempted to go and submit a claim to Anthem as the primary coverage, Anthem's response is this was already a paid claim because they paid Passport, they didn't pay us. So there's some concerns there because we do have contracted rates with other payers for which we would be entitled to that, but Passport is preventing us from being able to bill those because they receive their payment from the third party coverage, commercial coverage. And so that prevents us from being able to do the proper coordination of benefits orders that we would want to do. We want to bill our primary coverage and then bill Medicaid as the secondary, just like we would in a normal situation if we had identified it up front. So it's causing us some issues in reconciling, but it's also causing us some issues in getting the reimbursement that we would expect to receive for those services when it's valid. But the bigger concern we had is the loading of information that was in contrast to what DMS has loaded in the chemist system. A lot of times we were able to find out that yes, DMS did have record of that coverage that had termed, and it was correctly loaded in the chemist system. But Passport wasn't relying on that. They were relying on their third-party information to support that. And what we would ask is the state would have exercised some oversight into ensuring that there is a single source of truth when it comes to coordination benefits information. Ideally, the state would probably want the MCOs to communicate with them when they find coverage so that everything stays synchronized. But that's not the case today, as Chemist has a piece of information, the MCOs have a piece of information, and they don't reconcile with one another.
Okay, and Chris, and I know I believe Teresa has mentioned to me that that is something that has come up in the past. I believe kind of that exact example. I am going to have to defer to her a little bit, to kind of walk that back and work our way through that. So as you send over those examples, we will take a look at that and we will meet internally and try to get a response back to you on that.
Okay. And then I would have one other ask of this process. The situation I described where the MCO is receiving payment from the commercial coverage directly in lieu of us being able to do that. What we were told by Passport is they were using the subrogation rule that is in the state contract. But typically subrogation is in regards to any insurance company having an interest in some sort of liability coverage in being a party to recovering the cost of that care. So it's typically auto, workers' comp, homeowners, or commercial liability where there's an accident or injury involved. But we don't believe that it's correctly interpreted for commercial medical coverage to be part of the definition of subrogation.
So Chris, how are you getting your commercial rate? Your contracted rate?
We're not. We have to settle for the Medicaid reimbursement because Passport has paid us and adjudicated and kept any ability for us to go back and get our commercial rates from that primary coverage.
So is Passport making money on the claim?
I would assume that they're recovering only their portion of it. We're the ones that are
Losing out
at the lower reimbursement rate.
Yeah, you're the one that's losing out on it because you can't bill under your contract.
Correct.
So that was another ask that we had to have a work group to talk about, the definition of subrogation and whether or not that applies in this situation.
And Chris, is Passport the only MCO doing this at the present time?
We're aware of Aetna Better Health also doing a similar process of subrogation, um, as well as some offset situations. So it's similar. But for us in Region 3, we still have that historical volume of Passport being the largest member coverage. So for us, Aetna Better Health is a little bit further down in the volume impact. For us, Passport is a huge amount of our members that we see.
Thank you.
Do we
So
have
Chris,
any other examples?
Chris Turner, do we need examples of that practice as well?
Yes, if you could please send those as well. Yes,
Okay. And that template's in the chat, as I understand it, right?
correct. Yes.
Thank you, ma'am.
Mhm.
Any more questions on this item? Chris Wilson, thanks for attending and weighing in. Appreciate it. All right.
So Russ, excuse me, this is
Yeah,
Barbara Wash again. We
yeah,
do have Steve Bechtel here online.
Steve. All right. All right, we'll go back up to the top to the HRIP. So Steve, what we kind of described was, we appreciate so appreciative of getting the updated rates for 2026 and the 2026 approval. There have been a lot of questions from the hospitals that I've fielded. What I understand is that, like, so in 2025, we had a target of 2.4 billion. I understand we were running closer to 2.7 billion at the end of the day. And in prior years, when we were over the target, what I understand is that DMS went to CMS and CMS approved those. Um, what I've heard is that in 2026 and going forward, that there will no longer be approvals for those overages. And if that's the case, so that's the first question, is that correct? And if that's the case, in 2026, if the target is, or the budget, you can call it just 2.8 billion, what is has DMS thought about the process of how that is going to work to keep us from going over? Is it going to play claims out until there's no more money? Is it going to split equally by quarter? Each one of those scenarios, or any other scenario, probably has pros and cons and good and bad in a lot of different ways. Um, just curious to what the cabinet has thought about or DMS has thought about in that, if what I understand is accurate.
Yeah, thank you. Can you all hear me?
Yep.
Okay. Sorry for my delay. I was trying to get in. I just got the buffering little thing for like 10 minutes to get in here. But yeah, Russ, that is correct. As you know, in HR 1, that was passed July the 4th and signed by the president, it puts in there that we are frozen at the dollar amount. So we will not be allowed to exceed that 2026 amount, which is even more the better that we were able to work through congressional leadership to get them to kind of relook or revisit what they were going to set as our grandfathered amount. That's what they call it, is a grandfathered amount. They were going to make it our 2025 amount, but we have not yet sent in the amended. So it was going to really put this program at a great underfunding mechanism. So just yes, you are correct. The original amount that was sent for 25 was 2.4. Actually, but when we pay it out, you have to pay it based off actual utilization, and so that utilization has increased a little bit to where we were. Well, I will just say that it's kind of, without getting into the weeds too much, but if you remember, we set these 25, the calendar year 25, we used 2021 historical data. And we did that that's the same data we used for the calendar year 2024. And the reason why we did that, if you recall, there was some ask or some request that we speed this up so that we can get the approval so hospitals can have a better way of budgeting for it in the future. So we tried to do that, but then as soon as we submitted it, I believe we submitted it in April or March, I can't remember, of 2025. Then the House Resolution 1 got dropped immediately afterwards. So, and I believe it got dropped in May. And so, therefore, everything at CMS got put on hold. They didn't want to proceed, and everything got just put on hold. So it kind of blew holes in our plan, so to speak, of trying to get that sped up, that process. So now we're back to we got the approval for 2026 at the higher amount that we asked for, not the 25 amount. So the amount that we did for 25, like I said, the original amount was 2.4 billion. What actual utilization and after quality, after you allow for quality, it's going to come up to about 2.7 billion. So there's about 300 million increase right there.
Yep.
And then then in 26, we did a $2.8 billion increase. It went up to 2.8 is what we got approved. So that's another like 120 million, I believe. So it equated to almost a little over $400 million when you look at it compared to the actual what was originally sent. Now we have submitted the amended preprint. We submitted it Friday to CMS for the 2025 year to increase that amount up to the 2.7. We don't believe that should be a problem because we're still below the grandfathered amount of 2.8. But I will just say this, that we don't think it should be a problem. However, I don't know how to interpret the waters at CMS anymore because it just seems like what I think is going to happen doesn't happen. So it's hard to tell, but we're going to do everything under our power to make sure that it goes through because we can show that it was based off the actual utilization. To your point of how we address it, we do not have to put it into, this is a program that is paid as a separate payment term right now, which means it's not built into the capitation rates that are paid to the MCOs. We funnel it through. It's more like a pass-through payment through the MCOs where they don't assume any risk at all on that. We make them whole and they make you all whole, so to speak. Then going forward, there's multiple things that we have to consider. In 28, we have our first 10% reduction per HR1. Don't know what that reduction. We're waiting on CMS guidance on what that reduction is. I mean, you can look at 10% reduction. Is it 10% of the total? Is it 10% of the add-on amount? Is it 10% of the ACR level? What's the 10% reduction of? I've asked that question to CMS in person at various conferences, and I've asked that on the phone and an email, and I've yet to get any direct answers just yet of what that's going to be. But in order for us to determine what to build into the rates, we need to know how much our grandfathered minus the 10% is going to be. What we envisioned, like you said, we have looked at several different ways. There's pros and cons of every way. We're trying to look at the best way to do it to maximize the dollars coming into the state because I do have a statute that I have to make sure that I follow, that I maximize the federal participation. So we're trying to figure out what is the best way from a mechanism standpoint. However, we're still waiting again on guidance on CMS on what that looks like, what they envision, what they will approve. do we, like you said, do we back out the 10% of the of the amount and say, okay, that's going to be set aside for quality, and then the other 90% we split evenly over 4 quarters and prorate it out? Or do we just pull that 90% over to one pot and pay every quarter until we get to the last quarter, and then that last quarter we prorate it out? Or we, in the cases that we're not that maybe our utilization goes down, are they going to allow me to change the add-ons for that fourth quarter to maximize up to the total dollar? So there's like 3 or 4 options to look at. We're still in the process of trying to think through that. But again, it ultimately it comes down to what CMS will allow us to do. So we have yet to get that guidance. So that's big. So the first thing that we're going to do is submit the 25 amendment, which I just did Friday. We have the 26 approved at the higher amount. We know what the amount's going to be in 27. 27 is still the 2.8. That's our grandfathered frozen amount. But I still have to submit a preprint. So we're in the process of pulling projected utilization and things like that so that we can go ahead. Our hopes is to get 27's preprint filed sometime by the end of May if possible, so that we can try to get that approval before last minute like we've been getting here lately, so that we can give you all some sense of budgeting and forecasting on your all's end. But the add-on may go down depending on if we think of, if we see utilization increase, and your add-on will decrease, right? So it has to come up to that grandfathered amount of the 2.8. I know that's a lot of information that I'm spouting off. It's nothing new. Medicaid is a complex animal, and it gets very complex when you're dealing with moving parts, so to speak, with House Resolution 1 coming down the pipe in 2028. So I know it was a lot. If I can answer any questions, I'd be glad to.
I think I'll get it to my TAC members, but I appreciate all the efforts. Very appreciative that we've gotten the higher amount, the 2.8 versus the 2.4 that we could have had. I think, knowing how we're going to do it so that we can plan appropriately, right, for cash flow and payments and budget purposes, I think will be important to the hospitals.
And I'll say this too, Russ. When House Resolution 1 came out, I started reviewing it, and I was like, I was told by the CBO, Congressional Budget Office, that if we had something submitted by the time that the date, that the bill was filed and the bill was signed into law, that would be my or our, I won't say mine, but our grandfathered amount. So I was always under the impression we would get the 2.8. However, then in September, we got a dear colleague letter from CMS saying that, no, you are outside the date by 1 day. You're going to have to go back to your 2025 amount. And that's when I started getting nervous, because I knew we hadn't submitted the amended for 25 yet. And that was going to put us at risk there. So I'm so glad that our congressional leaders were able to, I don't know how to say it, but just to be blunt, but talk some sense into some people up there. So
yeah, I'm very appreciative too. It was good news for 3 years, right?
Yeah.
The 25 and the 26 and the 27. The 2028 it'd be the first year when it has, as the rules stand right now, that it would have to go into the MCOs, right?
Correct. Right now it's 2028. It'll go into we got managed care final rules and HR1 things that we have to manage. It's kind of like juggling a lot of things at one time. So yeah, we have to put no more, what we're not allowed to do any longer due to managed care final rules is in 28. We cannot no longer have separate payment terms. Everything has to go through the MCO capitation process, and we're not allowed to do reconciliations any longer. So those two things are problematic for pretty much all of our all of our preprints. Are directed payments. I call them preprints. I know you all call them directed payments, but that's the preprint is the actual application that we submit. So.
Got it. Lori or Elaine, any questions for Steve?
Yeah, well, first of all, I want to echo what Russ said. Truly, truly appreciate all the work that you did and our legislators did to get us to the 2.8. Do you have any, and the answer is probably no, but as we talk about, as soon as we know how those payments are going to be distributed, and like we said, do they get distributed and then when the money runs out, and do you have a separate pool? Any approximate ETA of when you may have an idea of how that's going to work, again, just for cash flow purposes and anticipating as we get through this year?
What we envision right now, until we get further guidance from CMS, is to pretty much status quo of processing the claims and payments, with the effect that, because we don't, we're just going to do status quo for now. We're going to make sure that the 2.8 will pull out the 280 million that will be for the 10% quality, and then the rest of it will be the amount that we'll monitor each quarter. But that leaves the fourth quarter, right? The fourth quarter, what does that look like? And we can do two different things. We can just say, okay, we're going to prorate it out till we get up to the max, or we haven't come to that conclusion. As far as an ETA, my biggest goal right now is just to get the preprint submitted for 27 so that we can get the approval, and then we can discuss the mechanics of how we look at that. But my first indication would be just to keep it status quo so that we don't make any changes and make it look like we're making changes to CMS, because once you start saying, oh, well, we're going to change this process, then it halts the program a little bit because they want to vet it out. So that's my first hunch, but I will say that we are still analyzing all those multiple possibilities, but we wouldn't make any decision. We have y'all are represented by KHA on our calls. We have a weekly call, a trip call that we talk through a lot of this. We haven't gotten to these discussions just yet, but when we do, they'll be a part of that.
Great, thank you.
Mm-hmm.
I don't have any questions, Steve. Just appreciate, very grateful for all the work the team did to get the 26 rates as opposed to the 25. That was a big, big help to all of us. Thank you.
Yeah, and I appreciate you saying the team, because it ain't me. I'm not doing it all. I've got a team of people, and Myers and Stauffer has been a great partner, as well as my staff, the staff that we have here, the department that's helped us with this. It's been a team effort. KHA has been a part of the team as well, even though they're not state or our contractor. I still consider them a part of our team. So it was a team effort. So I appreciate it.
Well, we're all, the hospital side, we're all facing some not so fun going forward years, right? With how these things are changing, and I was getting just hit after hit, and this was a good positive outcome for us. And so again, we thank you very much. And
I will point out though, Russ, you may have gotten some calls from some of the losers, right? What I call losers. We got winners and losers, because the way that this program works, it's an average, statewide average ACR. So there are some people that are losing in this, but we are we're still operating under the same assumptions and the same process that we've been doing. I think where the disconnect was some people I've heard from are saying, well, we're not seeing the $400 million increase. Well, I don't think they were looking at the 27. The 25 amount being increased by like almost 300, and then the rest of it, about 70% of the 400 is in 27, which you're already getting pretty much at this time. So
Yeah.
really, the increase is like 125 million is what you're getting from the new
And I think,
27 to the 28 amount.
and I think, when you look at the actual spend, Steve, if I got the number right, it was over 2.8 and 24, right, with our overages.
Mm-hmm.
So, it run until 2.7 now, right? So it looks to some people that it was less, right? But it's really, we've been over our target or the preprint estimates both years, right? And
Correct.
they were pretty close. And so when you're looking at the actual, right, versus what we should have gotten under the preprint, it kind of skews it a little bit. And that's what I tried to explain to a few of them, is that in 24 we had a bigger number than when we're looking at 25. So if you see the 25 number being a little bit less than 24, that's possible depending on your utilization. And then, when you're modeling that against the new add-ons for 26, right, most people were seeing like a small increase, right, which was what you'd expect, because again, we're modeling on utilization that's running a little bit heavier than the preprint.
Correct.
So,
And I'll remind you too, on the preprint, which is the application, line 4 says estimate amount, estimated amount. And so we've put that as the estimated amount, but now for 28, that is our hard lined amount. So that's it's changed the
well,
definition a little bit
I'm
for that
glad
line.
I'm glad it's 2.8 for 26 and 27, very much so.
Yeah.
So,
All right.
thanks, Steve.
All right. Thank you.
Appreciate the update.
Mhm.
All right, back to the old items, prepayment reviews. This item, I think, came out of a St. Elizabeth item that's been going on from several months last year, and WellCare, where there's a clinical program integrity initiative. And that last May, I pulled the behavioral health TAC presentation by Jennifer. When did I say this wrong? Dadinsky on Medicaid audits, and it had a whole section about prepayment reviews and what the new rules were effective for calendar 24, where the MCOs had to submit, had to do, it was a real deliberate process. They couldn't just do a prepayment review because they wanted to. There were steps. Provider had to be notified. There had to be, and it was a limited time frame. But there was a bunch of rules, and this kind of fell out. This this clinical program integrity initiative, the CPI, that Optum led, kind of fell out from that. And I know there was a lot of reports that were promised, and a lot of information back and forth. And I don't know if Lori has anything else she wants to say on it, but just want to bring this back up to see. I know DMS had reached out to WellCare on it at the last meeting, and there weren't any updates. And I know Jennifer hadn't received anything, and so bringing this back to the forefront.
Christine or Kyle, can you address whether that's improved?
This is Christine from St. Elizabeth. I mean, we still get by far the most volume of pre and post pay audits come from WellCare. I think when we had our information session with WellCare, we were just trying to understand the program and also trying to understand what a provider would need to do to be released from the review. Meaning, like, is there a quality threshold? Is there at some points, where they're asking for records, and then we've met a threshold and then no longer would be reviewed at that point. So we did get some clarifying information about their review. I think in the last KHA call, DMS did state that it was okay for them to be doing the reviews in the way that they are because they're coding reviews. When I originally met with WellCare, they kind of were on the stance that it wasn't that they suspected fraud, waste, and abuse why they were asking for the records. It was more of that's how they were maintaining provider compliance with coding regulations. So they're asking for records to check to see, are we being compliant? What we did gain from the conversation is we were able to work with WellCare to get a series of reports where they could kind of identify where they were seeing the most record requests for St. Elizabeth. So that kind of gave us an opportunity to see maybe where they're focused. I think our biggest issue with how WellCare does this process is they just send us a request from Optum requesting records, but they're not really telling us what they're looking for. They're not really telling us what they're auditing. So we can't create a medical record packet, right, that is specifically addressing the issue where they have the concern. So it's kind of a blind request from the providers, and we don't know why they want the records, but we are obligated to provide them. When they have a coding initiative, this PPI process, where they are looking for something specific when they make the request, but they're not making that clear to the provider. I think that's kind of the bigger issue that I have.
But Christine, that to me, that's a post-payment review. Okay. If you're going to
We
ask
get
me
them both.
for
We get them before we
record,
get paid and after
no,
the
but
payment.
the prepayment reviews, they're again, so I know Jennifer's on, but there's requests that have to go to DMS. There has to be a summary of the concern, the provider ID. There has to be a provider notice, a start date of the review. It has to be very targeted and very specific. This is my issue for prepayment review. Now, post-payment review is a different animal, but the prepayment review, and I got the same issue with the E&M downcodings. If you're putting something through an algorithm and you're reviewing every claim for every provider before you pay it on an E&M level, and there's no denial letter, there's no concern of wastewater abuse, there's no identified problem, that shouldn't be a prepayment review. You should pay it and then deny it on the backside with a letter, and then we talk about it. But the idea that, from my viewpoint, that these prepayment reviews are going through without following the guidelines that DMS put out there, I've got an issue with.
I agree. It just seemed like the conversation was leaning kind of the other way in the fall last week on DMS's support of this being considered a prepay review.
So I know Jennifer's here. I don't know if she wants to weigh in.
Well, I don't know if somebody from Chelsea or Jeremy's team is on, because I think they were handling the specifics with WellCare on that. So I don't know if they're on.
Hi,
I don't want to.
it's Chelsea. I had my hand raised, but I
Okay.
sorry. No problem, Jennifer.
I'll turn it over to you for a second then.
Yeah, so I think there's a distinction here that we have to make between the prepayment review that's required for section 34.2 of the DMS MCO contract, and then the type of review that is being that CPI is providing for WellCare. And so, the prepayment review process in the managed care contract is applied only to providers who have demonstrated a sustained or high level of payment errors. So this is a targeted process for specific providers, and it's not applied across the entire network, such as Optum's CPI program. So in other words, prepayment review is kind of a corrective measure for providers with a history of errors, while Optum's CPI is a claim editing tool that applies their edits uniformly across the entire network. So that's the kind of the important thing to note, is that the CPI program does not target specific providers. It reviews claims across the board, and the requirement in the contract that this fulfills for the MCO is Appendix D, which is our management information system requirements. CPI is a state-approved claims editing initiative. It applies to all claims across the provider network. It's just part of the claims editing and auditing process that's outlined in the contract. And the purpose is really to identify potential billing errors and then ensure that claims, are substantiated properly before payment.
So Christine,
I don't know if
so Christine, the CPI that Christine, the CPI that you're experiencing, is it claim edit driven?
That is what they say.
But what are they denying on it?
Hold on, let me pull up my report. Sorry, I wasn't ready to have
Sorry.
that. Give me just a moment. I can get that for you.
And, I will say while you're looking for that, Christine, if WellCare, if our WellCare, folks are on and would like to, address any more context to this, I know part of our, DMS's review that we, wanted to ensure WellCare, made clear with the vendor is that there is a distinction between prepayment review according to the MCO contract and this type of prepayment review that's claims edit focused. So I know they were working on maybe, including some tailored reports for individual providers who were experiencing, really high volume of those flagged errors.
I mean, they're asking for medical records. That doesn't sound like a claim edit.
So
Right.
what their analytics look for is NCCI modifier override, DRG rules, professional claims for select surgical procedures exceeding targeted dollar threshold, facility unbundling of outpatient services while inpatient, cross-coder outpatient facility surgical claims, multiple E&M codes same day, suspicion of upcoding, frequency of overriding CCI edits, frequent unbundled recipient services, unusual superficial deep impact, implant removals, potential upcoded musculoskeletal excision procedures, misbilling third order, catheter placement, distal, sorry, help stay with me on pronouncing some of these words, distal claviculectomy, incorrect coding, upcoding of complex cataract surgery, high dollar hardware, high dollar IV hydration, hydration with IVP, IVBP, facility outpatient, excessive hours of service, unlikely frequency of radiation therapy planning and management codes, and incorrect billing of CPT 88305 for prostate biopsies.
Okay.
That was on the crosswalk that we were provided.
So it's a crosswalk, but some of those are pretty gray and nebulous, right? What's the parameter?
I mean, they don't tell us specifically. I mean, like the DRG one, I'm assuming they're just looking for suspicion of upcoding. But which codes are they suspicious of?
What's the threshold for a high dollar hardware? What's the threshold for
Yeah, that's not identified.
IV? What's the parameters, right?
Correct.
So I guess from DMS, should we not, if they're applying all this, should there not be the parameters that are shared, or do they get to change and make the rules at will?
No, I mean, we requested as part of our review again that WellCare, the one issue that we saw was the communication, the transparency. And so that was one take back that they committed to, was identifying where they could improve in those areas. And I would love if there's some folks from WellCare on who would like to address some of this as well, because just kind of maybe outlining the corrective actions or corrective measures you all are taking around at least the transparency and ensuring that the provider understands what they need to be providing or potentially appealing, et cetera. Anyone from WellCare want to address that?
I think that's part of the issue.
Yeah, I agree with you,
They're
Russ.
using an Optum product, and nobody understands it, right? It's like the E&M piece, is that nobody understands and nobody has the parameters that they can share about why they're doing anything, why they're denying something, what makes it a high threshold, right? Is it $50? Is it $5,000? What is it? And we're left to guess. Can't appeal it intelligently or correctly because they don't know what the parameter that it was denied under. And that, I mean, this is Groundhog's Day. This repeats over and over and over again. We've got to have transparency about this is why this thing was denied. This is the reason, so that we can adequately appeal it and fight it and try to argue it. but not knowing it because it's an Optum proprietary software and it's a black box isn't acceptable.
Yeah. I'm inclined to agree with you, Russ. I definitely, again, as I said, that was one thing that, we were most concerned about was the transparency piece. And so, I know we don't have maybe the right individuals on the call today from WellCare to address, but I will follow up with them after this call today.
Okay.
Because I need to get a little bit more information around that piece, and I can provide a response back to the TAC once I get some more information about, the transparency piece and what they're getting to rectify those concerns.
That'd be great. And Chelsea, we're having monthly kind of touch bases with me and the
Yes.
folks from DMS on our items, so that we don't have to wait next next TAC meeting. If you get something that would, more than welcome to join us at the touch bases that we're scheduling to so we can discuss it more. But I appreciate that effort, please.
If there are people on from WellCare, can we request that someone who can answer this question be on the next TAC meeting?
We can request. Rosman, will you remind me to carry that water to the WellCare folks?
Sure will.
Thank you.
Thank you.
All right. The IMD partial hospitalization. I think, as I understand it, this kind of out of my realm a little bit, but there were some questions about the 15-day limit. I know those days are changing. I know we had an update at the pre-call for this. Can someone from DMS talk about this a little bit?
Hi, my name is Heather Graham. I'm a behavioral health specialist within the Department of Medicaid Services, and I was asked to join today to talk about the 1115 for serious mental illness. And I'm not sure exactly all of the questions that you may have, but hopefully I can address anything that you're needing to know. As far as the SMI 1115 went live on January the 15th. And so that did extend the 15-day in lieu of service is what previously has been acceptable for MCOs to pay for inpatient short-term psych services for beneficiaries who are 21 to 64. As of January 15th, that has changed to up to 60 days. So that definitely gave some extra parameters there for being able to bill those services.
But what I understood is that if it goes
Yeah,
past that day limit, the whole claim is denied, right?
correct. The stay cannot exceed 60 days.
So if it's 61, you don't get paid from 0 to 60.
Correct.
Okay. Questions from the TAC group? Rosman, is there something I'm missing on that?
Yes, I think this partial hospitalization item is left over from a provider notice that was issued back in 2023, and we're still waiting on a rescission from the department on that piece.
Rosamond, help me is this a telehealth question for partial hospitalization?
Yes, it is.
Okay. So I do know that the guidance, the last recent guidance, and I want to make sure that I speak to this correctly, was going to be updated, but then CMS has recently also been giving guidance in October and December, and then again in February about changing in any of their telehealth where it had been acceptable during the PHE, the public health emergency, and then what had been changed. And so they've changed some of their behavioral health pieces. I know that moving forward, we were going to look at what date to retro or set an effective date for that based on what CMS has provided. And so from what recently came out, it looks like the most recent one came out the 17th. And it looks like they're going to possibly extend to December of 2027 for whatever was existing. But we haven't gotten clear guidance from them on if that also applies in this other settings because it came out for Medicare. And so we're trying to untangle and get that guidance back to you. That did get brought up. It's on the top of our to-do list. Friday we had another discussion about it too to try to get you guys an answer. Like I said, I think it was ready to be put out, and then the guidance changed again from CMS. And so I think that's where we've been trying to untangle. And I hope I've spoke to that correct, like all of those pieces that are missing. And I'll take it back to Angela and Sherry as well and make sure that I didn't miss any of those pieces.
Yeah, we've asked for additional information and a rescission on that particular provider notice since October, since it came out. And we've heard in different settings, yes, they were going to issue it. And maybe to your point, the guidance has changed. So we're just continuing to follow up on this because it does prevent people from accessing services. And none of the hospitals are willing to, at least as far as I know, none of them are willing to start providing these services without that kind of rescission and guidance from the department. So we really appreciate your follow-up on this. Thank you.
Okay. And it was my understanding too that the services, if they were previously being provided telehealth, they're no longer being provided until this guidance is given. Right? That's what you were referring to, Rosman.
Yes, when the
Okay.
guidance came out that said there was no payment for these services and that they weren't going to be allowed, those services stopped.
Okay. Thank you. That I want to just make sure I heard that correctly. Okay. Yeah, and that's where I know it was in October. The date on the letter draft that I have was October of 2025. And then the next stall I got was from additional guidance that came out in December. So we're looking at it and I'll try to get a response as soon as possible. And I'm sorry for the delay. It really is fun trying to navigate some of the CMS pieces when it is switching very rapidly.
Thank you, Heather. Any other input or questions on this? All right. Okay, move down to denials, DRG downgrading. This one was kind of in tandem with the newborn. So we're seeing downgrades on neonatal DRGs to a normal newborn DRG if the MCO doesn't see the level of care is on the account. So if a newborn doesn't stay a night in the NICU, we're seeing this as where it's being downgraded automatically, sometimes not getting payment at all. What I understand is WellCare is specifically saying they can't substantiate the DRG and they're paying zero. And that's a newborn that they're paying zero on. The contention from the hospitals is that it's a diagnosis related group methodology. It's not a level an accommodation methodology, whether it be a per diem where you've got an ICU or a med surge or a normal newborn. And it's the DRGs are driven by the diagnoses on the bill. And I know I've seen my own share of MCOs taking newborn or neonatal DRGs and reviewing those diagnoses that are there and challenging those. But the automatic downgrade to a normal newborn when there's not a NICU is out of line from the viewpoint of our members, and especially getting a zero payment on something that they say they can't substantiate a DRG, which is should never happen.
May I add something to what you just stated?
Sure.
I'm Danette Warford with U of L Health, and a portion of the DRG downgrades that we've been bringing to the KHA group for quite some time now aren't specific to the neonatal group. So I just wanted to make that distinction. I do know that that is an issue. You're absolutely right in the way you presented it. But we have an older group of an accounts that we've been working with WellCare on for quite some time, where they reviewed accounts and said different things. They use different verbiage at different times. They'll either say that they're downgrading it. We fought with them quite a bit over these. They've paid several of them, but we still have like at least, I believe, 12 accounts outstanding. They're very old, where they've either paid and then recouped the money, or they've never paid us any money, but we have no dollars. And their reasons are that they said that they couldn't substantiate a DRG. And they claim that that's not a DRG downgrade. They're trying to distinguish that. But our stance has been, we've provided you with the full medical records. It was an approved inpatient stay. So there has to be a reimbursable DRG. You know, we may disagree on what that is based on your review of the coding and our review of the coding, but our stance is we should at a minimum be paid what they determined to be the DRG for that account at a very minimum. And they've not done that. They're paying us zero and stating that that is appropriate.
So I know DMS was looking at this issue and reaching out to the MCOs. Do we have any follow-up?
So this is Jeff at the Passport. I can jump in and just say we've been reviewing a number of different DRG downgrade questions and zero pays, and we actually last week, even on the KHA call, just kind of broke it down into different categories to identify what was happening there. So it looked like it wasn't a downgrade or a no pay for services that were authorized, but it was just different edits that were firing and different reasons for the payment changing. And we've looked at a few different things. Some were because of a itemized bill that weren't provided. Some were a discharge status that was different than what was billed. Just various reasons. So on the newborn downgrades, though, I can say as long as it's a standard, not a NICU inpatient stay, but a routine one, we would pay that at the standard rate. If it is a higher level of care, we would just ask for those medical records to go with it, and we can reprocess that claim. If there are any other kind of DRG downgrades, we can look at those too if we have any other examples. And I'll actually tie that back to the newborn progeny authorization issue. So we did have an issue there. So if you get an authorization from progeny for an NICU stay and you bill a different code for it than what was authorized, we had a system upgrade that was denying those if the codes didn't match. We've recognized that was a problem, reprocessed claims, and fixed that already. So progeny claims should no longer deny. They should pay at whatever the authorized service was. Does that help?
It does, but I guess I have a question. So how can a accommodation drive a DRG change?
On which one?
So what I'm hearing you say is that if so say I have a full-term neonate that stays only in the newborn nursery, and it gets billed out based on the diagnoses that are on the bill as a full-term neonate. Am I hearing you say that because there's no neonatal accommodation room code on that bill, your system will downgrade that to a normal newborn DRG?
Well, if it's submitted with medical records, we're able to process it based on whatever the records are there. So if there are records that reflect a higher level of care being provided, then it would pay that higher level of care. If it's just being billed knowing that, different diagnoses are included in the claim for informational reasons, like a heart murmur per se, but no NICU stay was used or needed, then we would just pay that at the standard newborn rate.
Then you're not paying under DRG methodology then, right? At that point, Jeff.
It would
I
be the
mean,
standard
it's like
inpatient.
saying I won't pay sepsis unless there's an ICU account, ICU room code on the bill. You can have a DRG of sepsis without being in the ICU. It's a DRG, it's a diagnosis related group, right? And it's based on an average payment, right? There's winners and losers in every DRG, right? Because you have ones that are more sick and ones that are less sick. It's never the cost of my care and never spot on, right? Um, and so it's it's counter to the actual methodology that's been agreed to. There's
Yeah,
there's
so
there's
if
no
there's
place in the DRG methodology that says because you had this accommodation, we're going to change the DRG that is there. If you want to argue the diagnosis, that's a different story.
if the NICU was not used, we would pay at the routine newborn delivery fee.
That
If the
that's
NICU was
that's
used, we'll pay at
that's
whatever
the
was
that's the
authorized.
issue. A new neonatal DRG does not necessarily require, for it to be classified as a neonatal baby does not require necessarily a NICU accommodation.
Right. So in those instances, we would just require the medical records that would reflect the need for that higher level of stay. And then we would pay at that billed DRG based on whatever is reflected in the records there.
Okay, I don't think that's what's happening, but I will look to my group and my own internal ones to bring back more.
And
Um,
if you see anything different happening, I mean, by all means, we're happy to
so
look
I
at
mean,
those
if
examples and
if
figure it
you
out.
if that heart murmur is driving it to a DRG and that's in the normal newborn and you challenge the heart murmur, that's one thing, right? But if you don't challenge the heart murmur and say, yeah, that's a good diagnosis, but just because they're in a normal nursery versus a NICU bed, we're going to pay you the normal nursery and downgrade the DRG outside of how it would be really, how it should be grouped and how it should be paid. And that's where I've got the issue. That's where we have the issue.
And that's
Hospital.
that's just why we need the medical records because we don't have any other way of really knowing.
Okay. Um, any DMS follow-up? I know this has been on, and I know they were talking to the MCOs about this issue.
Yeah, we have again, there's several issues. So the issue you just discussed with the uh, newborns not being in the having to be neonatal, that's part of that issue we discussed that is in the work group that we're still meeting on. But
Okay.
the other issues on DRG downgrading, E&M downcoding, all those type things, and some of the things you talked about earlier, I think specifically, and I brought it up a little bit earlier too. I have an MCO policy clarification or an MCO policy letter that'll be going out either this week or early next week. That's going to talk about ensuring that any of our providers that are denied a service or have a service down coded or downgraded in any way, that they have clear and specific reasoning why that was denied or downgraded or downcoded, and then that they're giving the right and ability to appeal those specific reasons. So I think that's lacking in some of these issues.
Yeah.
And so we want to make sure that our providers have that opportunity. So that's going to be going out within the next week or two. And then as we get some more clarification from the meeting on the newborn issue that you just discussed, we'll be getting back with you all on that as well.
Okay.
If you have any the proposed language that you would, like to send over as far as what I just talked about, feel free to send that to me. We would always like to look at, thoughts before we send that out, making sure that we're being clear what you all need for those to be able to appeal those downgrades and denials. And
Yeah, I think I would like to talk to the TAC and have some input on that.
okay, I'll wait then. I'll wait to
Appreciate
send
that.
that. Yeah, I'll wait.
Can I ask a follow-up question, Justin?
Yep.
So to your point on the appeal, so what if we get to where they say the DRG is going to be downgraded or they can't substantiate the DRG? In our mind, those two both mean the same thing. There's going to be some type of downgrade. And let's say we agree with that downgrade and we say, okay, we're not going to appeal it based off the reason we don't really know the downgrade. To your point, maybe all those details aren't in your letter. So the clarification we're looking for is if we don't appeal that, should we pay zero? Should they pay us $0? Because in our mind, they would pay us what they downgraded to or what they were able to substantiate,
That's
not zero.
that's
Yeah,
correct. So yeah, we'll address that too.
Okay, that's what's happening in the
Yep.
issue that was described earlier by
Yes.
Danette in our well care downgrades and our well care claims that say they can't substantiate. If we don't appeal what they are saying, they're paying zero.
Yeah, we'll address that as well.
Okay. And then on those claims is the expectation to be interest to apply to those claims if they were denied in error or if they didn't just pay the downgrade that they were able to substantiate?
That's a Chelsea question on the interest payments for the MCOs.
Okay, so is that something we should ask in the clarification that Russ is going to put together? Because I see she had a drop.
Oh, okay, yeah, absolutely.
Okay, thank you.
So appreciate that, Justin. So that would kind of cover the line item denials is another one, right? Where we don't have really a process for appeal. There's little transparency in what they're doing. They're using a third party software or algorithm that really doesn't, that we don't really agree with. So that, for the E&M and the line items, that would kind of be covered in the wake
Yeah,
of.
it all goes together. We have no problem with our managed co-organization partners downgrading. We have no problem with them doing line item denials. We have no issue with them downcoding. But they have to make sure that they give our providers specific reasons why that happened. And when I say specific, I mean it needs to be detailed so that you all can appeal those things. And they need to give you the same exact appeal ability as they would anything else.
That's what I've been asking for a while. So I appreciate that very much.
I'm
Go ahead.
sorry, this is Jennifer at St. Elizabeth. Could I just ask one quick question just to expand on something that Russ mentioned? And it is exactly what we're seeing. And that's when the diagnosis code may be a heart murmur. And yes, we diagnosed that. We may not treat it here. We may have them follow up as outpatient with a specialty like a children's or something of that nature, but we're still billing that diagnosis. We still went through um, you know the diagnosing part of that, so that's still going to be on our claim, which is what drives it to the level 2, but then they aren't paying that level 2. So I think there needs to be some clarification and expansion on that in general. I understand the DRG downgrade, and yes, we should be getting paid at least a level 1 there, but there also needs to be clarification on whether or not that's acceptable, because in one way, Passport stating that if they don't go to NICU, that they are just a level 1, then backed it with, well, it depends on the diagnosis and the medical records. But we are often seeing where we do diagnose a higher level problem, they don't require a NICU stay. So therefore, yes, it is a level 2, but they're denying it as a level 2.
Yeah.
So do we have more, no, I mean, do we have more expansion on, like, I understand that, yes, they can downgrade, but should they be is the question.
Well, that piece that you just talked about is a separate issue. So that won't be addressed in this particular letter. We're still kind of going through and reviewing that. Like I said, with that group, there's a specialized group that's looking at the specific cases for newborns who have extenuating medical issues, but they're not in NICU.
Okay. Um, I saw that in the chat. I think Jeff at Molina put in the passport newborn NICU reimbursement link for their policy. So appreciate that. I'll take a look at that. Anybody from the TAC have any other items on these things that we talked about in old business?
I don't, Russ. Thank you.
Okay.
I don't either. Thanks.
Thank you, Lori. Thank you, Elaine. Any other discussion or other items?
Russ, can I mention something around the line item denials?
Sure, absolutely.
Just to clarify, these are, I believe the way these were addressed, these are audits that are completed by the payers where they disallow charges because they feel that they should not be billed separately. That's typically the language that we see in those audits. It's not that they're denying them, saying that they weren't provided. It's not that they're denying them, saying that there's a reason why they shouldn't be. Their wording typically says that they believe that this particular charge, let's say it's a ventilator charge, should be covered in the room and board charge. That's the type of language we see with what we've been discussing as line item denials in our KHA meetings are charge audits, where they disallow charges on our claims. That effectively reduces our billed charges, and based on the way our reimbursement's determined, that reduces how much we're paid. And because our reimbursement's based on the charge master that we all provide, they're in essence reducing our rate that's already been determined. We've already provided the fact that we bill all of these things this way. All of our charge masters are set for all of our payers. That's the information that's provided when our individual hospitals' reimbursement rates are determined. But the MCOs are taking that and saying, well, yes, that's your charge master, but we don't think you should charge that way. Therefore, we're disallowing this charge. We're removing it from your claim. And what that does is it reduces our reimbursement that the department's already determined is appropriate and at a level that helps us stay in business. So I just wanted to share that the line item denials that are listed here are those charge audit items where where the MCOs or their vendors are dictating how we charge things after we've already presented that in the reimbursement process.
And I would even take it further. So when the methodology from a DRG perspective, if from the Medicare side, a lot of these happen on outliers, right? They don't look at inliers, they look at outliers where there's an additional payment. And they take those charges, I've said this before, they take these charges and they say, okay, you shouldn't have charged separately for that. And I'll give you an example of one that's hit me. So an intubation kit, we charge for the kit and we charge for the handle. The handle is more than the kit because we don't charge that handle in the kit. They're different size handles, they cost different. So we charge people for what they use. We track it from a cost perspective for each case rather than including it into the kit where it gets lost and where I may charge for the higher item all the time. The way the CMS rules work and the methodology works is that it takes my charges and it reduces it by my cost to charge ratio, my own specific one. So CMS looks at my charges versus my cost that's on the cost report. So how I charge is already baked into the reimbursement. So the reduction of charges to say that that's bundled is just a pure rate cut. Because it's my charge, cost to charge ratio, not Elaine's, not Lori's, not a statewide. It's how my hospital charges and how I charge is already baked in. So when an MCO comes and they put it through again, a black box and an algorithm and says, you shouldn't charge that, then it's just a pure rate cut and it's not acceptable. I've had ones where the patient came in for a pacemaker and they've denied the pacemaker, the actual pacemaker. It's what they were there for. You get a pacemaker put in their chest. And it's again, Justin, as we do this, right, knowing specifically, right, why pacemaker when they came in for a pacemaker, or why this charge when this is how I charge is specifically excluded, should be specifically excluded, there's nothing that they can point back to. They point back to very, very nebulous and gray reasoning in a CMS reg. But CMS doesn't tell you how to charge. They just say you need to charge consistently. So we went through this with workers' comp payers about 10 to 15 years ago. And we continue to go through it with the MCOs, and it's a problem because what you've negotiated in your rates and the methodology is again, like the NICU newborn, is not being adhered to. All right. Anybody else? Any other items? General discussion? Don't have recommendation today, but I'm getting closer. The MAC meeting, that MAC's kind of changed. We don't do reports anymore unless we have recommendations, but I will be attending the MAC to hear it. And then our next meeting is April 21st, 2026, Tuesday. Nothing else. I appreciate everybody's time today. Thank you very much. We'll be adjourned.
Thank
Thank
you.
you.
Thank you.